Good evening. Well, good evening. Good afternoon. I hope everyone is doing well. I just want a quick check to see if people can hear me, see me, and see the presentation. Anyone who cannot see me, hear me, or see the presentation, please use your hand raise so that Rochelle and Nicole can see. Fantastic. It looks like everyone can see, hear, and we're ready to go. So my name is Matthew Katz of MCK Health Strategies and MCK Consulting. My conflicts are that I am a consultant to the Physicians Advocacy Institute, which is a national organization of medical associations, and I'm also on the New England Comparative Effectiveness Public Advisory Council, which is CPAC, for the Institute of Clinical Economic Research. So we do research and look at cost-benefit analysis of medications and treatments. A little bit about Physicians Advocacy Institute. It advocates for physicians, physician practices, and medical associations. It was founded tied to the multi-district litigation that the South Carolina Medical Association was an active participant in. More information about PAI can be found on its website, which is listed below, physiciansadvocacyinstitute.org, or you can contact me at my email address below, or Kelly Kenny, the PAI CEO, at that email address as well. And to let everyone know, the presentation will be available afterwards for download through the South Carolina Medical Association. This is the PAI website on COVID-19 that goes through their list of resources that all South Carolina Medical Association physicians and practices have access to. And it is updated regularly, and I encourage you to go there for additional information as well. So I always believe strongly in walking through what the agenda of the presentation is going to be at the onset, so people have a understanding, a level set of what we're going to do moving forward. So we're going to talk about what the landscape was prior to COVID. We're going to talk about some initial federal changes, primarily tied to Medicare and Medicaid. We're going to talk about some state legislative and regulatory changes that were across the nation and specifically here in South Carolina. We're going to have a general outlook of where we're headed, some practical steps for practices for some success, and then some time for question and answer. So let's talk about the landscape for a minute. Prior to COVID, we had an expansion of telehealth services, but it was evolving and going relatively slow. Medicare and Medicaid did cover some services, but not so many. Payment requirements caused everyone to go a bit haywire. And the new models of care, such as value-based care, confused how to cover or not cover telehealth and telemedicine services. So PAI and South Carolina Medical Association has prepared this presentation so that you can better navigate the telehealth environment. This is going to give you an understanding of the rules and regulations to live by today, which will probably change by tomorrow, and help you with some practical guides to moving forward in your practice, whether you've started telehealth and telemedicine or you are looking at starting doing so. So before COVID, in the Medicare fee-for-service space, it really only covered a few things. Virtual check-ins, e-visits, limited telehealth was covered. Medicaid was a little more flexible, state-specific, permitted telephones and other devices, but again, nationally not so flexible for patients or physicians. Private coverage was a little more flexible, but it varied significantly, even within a health plan by state and by product. This again is pre-COVID. Telehealth, as I mentioned, pre-COVID by CMS only covered beneficiaries really in designated rural areas. Now, South Carolina has a lot of those healthcare professional shortage areas and designated rural areas. So prior to COVID, there were a lot of parts of South Carolina where these services could be provided and could be reimbursed by a physician, but a physician doing it in their practice, not at their home, with a patient who was at a different practice site, not at their home, and at these other sites. So very different than today. It was very limited, very restricted by geography, type of service, and who could do it. The services, again, were covered only for patients that were established. you had to have seen the patient in a face-to-face encounter prior to providing that telehealth telemedicine service in order for it to be covered. It could only be done by physicians, physician assistants, nurse practitioners, and a few others. There were also a limitation on some codes that could be used. So again, it was limited utility for the patient or the doctor prior to COVID. So what has happened since? We're going to talk through Medicare, Medicaid changes, Office of Inspector General for Department of Health and Human Services, HIPAA changes or waivers, and some state licensure changes that have allowed more flexibility within the telehealth market space. So the first thing that happened in March was that the Department of Health and Human Services waived HIPAA penalties and barriers. Why is this important? This is important because most of what guided the restriction or limitation on care provision was tied to HIPAA security, confidentiality, and transparency aspects of under HIPAA. So you had a lot of restrictions that really limited a physician's ability to interact with their patient. The DHHS said, we're going to waive some of those so that you have greater access. They applied it to audio, to text, to video. They did it for Medicare, Medicaid beneficiaries, a few other patients, and they allowed physicians, nurses, and hospitals to have this waiver, temporary waiver, mind you. That was in March. In addition, CMS waived the licensure requirements. What they previously required is that the doctor be licensed in the state of care, so that if you were seeing a patient in North Carolina as a physician in South Carolina, you would have to have a North Carolina license. They waived that so long as for Medicare, and they also waived the fact that the in-person face-to-face encounter had to occur, or they said they weren't going to look the other way initially. They also simply required you to be enrolled in Medicare. States could also request waivers of licensure for Medicaid at that time. So again, this was early March. On March 6th, CMS expanded telehealth coverage to include when you're doing it in other locations and providing it in the home. So remember, before it had to be a physician in their office providing it to a patient in another physician's office or some other clinical location. They expanded it March 6th to go beyond that. So this was the first time you could provide your office to some other location, patient to physician encounters under Medicare. Also March 6th, they said they will not conduct certain audits during the emergency period, which was good, and they will not enforce certain requirements. Of course, all of these are during the federally identified emergency. So we'll get into what happens afterwards in a bit. On March 17th, they further made changes. They allowed waiver of cost sharing for telehealth services. They also expanded the services that could be done for the first time. So you've got telehealth in addition to virtual check-ins, in addition to e-visits. You can now do remote care management, remote monitoring. The other thing they did was they waived most patient co-payments, co-insurance, and deductibles. However, they didn't, and they encouraged physicians and other clinicians to also waive. But if you waived those, then you weren't getting payment in many cases, because many cases the consumer had not met their deductible. So basically you were waiving the entire visit. But Medicare waived the cost sharing for the consumer, but that didn't mean that the provider had to at that time. On March 30th, they further expanded it to nursing homes, assisted living facilities, and home care. In addition, what was started out at 6 CPT codes or services that were authorized, Medicare expanded it to 80 services. It's now at 86. And the technology, they then allowed audio-only visits to be permitted, which weren't permitted before. You still had the problem of the fact that there wasn't parity prior to this, but at least they expanded the services. In addition, instead of just waiving requirements, they eliminated the established patient requirement. So you could see new patients by telehealth for the first time March 30th, but it was retroed to March 1st. They also allowed you to disregard certain carrier decisions that had been made by different Medicare carriers under fee-for-service, and they lifted some inpatient and skilled nursing requirements. Even though they did this, not everyone was able to use services. So, for example, if you had an orthopedic practice, you were aware that you as an orthopod could bill for certain telehealth services that were physical therapy, occupational therapy, or if you had an ENT practice for speech and language, you could bill for them, but a PT, OT, or SLP couldn't. So what was interesting is they allowed the services, but not those other clinicians to bill. But CMS was given the authority to waive restrictions. They just didn't at that time. So these were the types of services as of March 30th, going back to March 1st, that could be done. And again, these are mostly E&M services, but it was updated March 30th to 80 services. So it's almost everything from that you would normally do as an initial office visit or a subsequent follow-up or home care or critical care services now was covered under Medicare. Other key changes, they said March 30th they're going to pay the same rate for these telehealth services that they would if it was a face-to-face encounter. Why did this matter? Because before, they were a very small percentage or portion of what the face-to-face reimbursement was. So as of March 30th, going back to March 1st, the services are now covered at parity. Parity meaning what the face-to-face rate is within Medicare. However, in order to get that, you have to make sure to put the modifiers, the 95 modifier, to identify the claim for claim line identification, and using the point of service code 02 or 11 for facility billing. Now, when this started, 02 was the common place of service, but more people are using the 11. Medicare says they will cover and reimburse for both 11 and 02. Some insurers only want the 11. So, and Medicaid is variable by state, whether they want the 02 or the 11, but everyone wants the 95 modifier or the GT modifier. That's another modifier for telehealth. It's whether you use the place of service 02 or 11 code for whether you're doing it in your office or at your home. And some say it doesn't matter if it's at your office or at home because your home is your office in some cases, so use the 11. But 2 is being used initially because people are doing it from their home. And then you have to document the time spent. It's critical. We know that CMS has said, HHS, they're not auditing now, but they haven't said they're not going to audit in the future. So documentation is critical. Document the time spent. And in this case, even though CPT codes are often not dictated by time, it's a component, it's an option for E&M services for most cases. In this case, document your time so that a level 3 that you have the time component documented. On April 23rd, and then again on May 22nd, they did further revisions specifically to Medicare Advantage. Prior to this, while Medicare fee-for-service was reimbursing, Medicare Advantage plans weren't. So on April 23rd, they said, MA plans, you're permitted to do what we're doing under Medicare fee-for-service. You can do the same thing. On May 22nd, they went even further, saying you can do even more than we do, and you don't have to report to us or change your benefit design. So April 23rd, they reminded MA plans, Medicare Advantage plans, those are the Medicare managed care plans for seniors, that they could waive deductibles, they could allow payment for all these telehealth services as long as Medicare was doing those. On May 22nd, they encouraged them to do that and even beyond without penalty. Now we go to the issue of funding. The CARES Act provided $180 million for nonprofits, hospitals, health systems for funding for telehealth networks and telehealth resources, because in many locations they didn't exist before. So the CARES Act provided that funding to be awarded in different phases to providers to help expand telehealth services. So what's happened to date? So far they've given $15 million out to 159 providers. workforce, education, practice area, and centers of excellence have all received funding for telehealth services. They haven't given it out to a particular individual physician or physician practice. They've given it out to systems, clinics, facilities, FQHCs, community centers, public health centers, but they are giving money on a rolling basis, and there are grant applications available. In addition, the CARES Act provided $200 million to the FCC to help expand access to care through telecommunication services. What does that mean? Teaching hospitals, community health centers, skilled nursing facilities were all able to get funding through a grant process. No grant would give more than $1 million, but there were plenty of grants available. To date, the FCC has given out $33 million to 89 providers in 25 states. My suggestion to many of you on this phone is if you are part of an FQHC, part of a system, part of a rural health center, tell someone who is doing the grant proposals at the state or federal level, or tell the financial folks, you have a unique opportunity to apply right now. These are all rolling grants. They're all online. They're all available. They're all based on need. And again, they range for the FCC from $0 to $1 million. And the grants from HRSA under the CARES Act are anywhere from $100,000 to $5 million. So there is opportunities, not for an individual practice, but for practices coming together, or clinics, or community service centers. In addition, the CARES Act allowed the insurers and allowed doctors, if they wanted to waive certain deductibles for high deductible health plans. The IRS said that you can do this retroactively. The important thing here is that a lot of patients were not paying for services, especially telehealth services, because of those high deductibles. And so this, the IRS made some changes to rules to allow HSAs and FSAs to be accessed for these deductibles. And prior, they couldn't be. So there was additional flexibility by the federal government for IRS purposes so that things could be used retroactively to January 1st. Because before, they couldn't be used for deductibles only for co-payments or co-insurance until the deductibles were met. This allows you to use them first dollar. In addition, the DEA and SAMHSA also made some changes and allow you to use telehealth services for things like narcotic treatment and opioid addiction treatment, which you couldn't do before. So under SAMHSA and under the DEA, you now can do more when it comes to telehealth services for prescribing and treating those with addiction. The FDA also committed to changing some of its market-based guidances tied to classes of prescriptions that could be prescribed online. It was restricted prior. They have relaxed some of those restrictions. On April 30th, they further waived some additional requirements, and they changed audio only so that audio only was on par to the other telehealth services, which are on par to the face-to-face services for Medicare. They also changed some additional practices tied to video requirements so that you can use almost any technology that allows that one-to-one interaction, where before they were more restrictive. So things like Zoom and Skype can be used now, where before they couldn't. On May 12th, just recently, they made further changes. They now allow interstate providers to reimburse for TRICARE. TRICARE, of course, is the VA system, non-VA providers in the facilities providing care outside of the facilities. So it took until May 12th before those providers were reimbursed for telehealth services and reimbursed at the in-network rates. They also eliminated co-payments and cost sharing for telehealth for veterans. It took, again, more than 2 months from when they started with Medicare to get to the VA, but they did it. It's unclear if it's retroactive to January 1, but at least starting May 12th, providing the services, you can get compensated and there is coverage. So here, one of the things I like to do is give a list of all of the resources that you can click on. These are abbreviated links to all of the sites that I've used to provide the information to you today, and things are constantly changing, but this is a list of all of them. So I encourage, if you have a question on a particular item, you can click on one of the links and you can go there and get right to the details. These links don't link you generally to a main page. They link you to something I said in my presentation in more detail. So let's talk a little bit about Medicaid and flexibility. On March 17th, CMS said states, you can be more flexible. Most states did. They were flexible before, they became even more flexible. No need to have the face-to-face, they said. They expanded all of it. Most states did expand, but it wasn't until April 23rd when the government came out and said what they would then reimburse the states for. The problem was this. They said, states, you can do all this, but they were silent on whether Medicare would be paying their portion for any of these things. Well, most states are going to say, wait a second, Medicaid's a shared program. We pay, the feds pay. They're saying we can do this, but they're not saying they're going to pay their portion. Maybe we shouldn't make the changes. So it wasn't until April 23rd that the federal government came out and said, this is how the coverage and reimbursement policies are going to work. These are the technology requirements, and these are the patient populations that are eligible. So most states didn't change their Medicaid reimbursement until April 23rd. Some made it retroactive, some didn't. That's not just for Medicaid, but also CHIP programs. Here are the resources for all the Medicaid places to find information and FAQs. Now let's talk a little bit about state laws. And I know I'm going fast and we'll have time for Q&A at the end. So states, again, had a myriad of different regulations and requirements. Mostly they said you had to be licensed in your respective state, and that the state where care was provided was the state that you had to have a license in as well. And they said you had to see the patient face-to-face initially. Not every state was that way, but that was what most states said. But all that changed with COVID. In fact, most states began waiving the licensure requirement almost immediately, recognizing that there were problems because of access. So 40 states have lessened telehealth and telemedicine service requirements. They either allowed an expansion of where that provider is, that physician is. It's not just a physician, it's other clinicians. What the relationship is with the patient, if you've ever seen them before, what patient characteristics. Some states had age limitations. Those went by the wayside for most states. And where the patient was, whether they were in your state or another state, that was waived. 27 states waived license requirements completely, saying as long as you're licensed somewhere in the United States, we'll let you see one of our patients. Again, risky generally, but during the pandemic, these states felt it was necessary. And most of these states that have waived these are those hot zone states like Connecticut, New York, Michigan, Wisconsin. That's who's waived these. But you have to keep up to date on these because some states, the waiver ended May 1st, others it ended May 31st. So if you're an out-of-state provider, you're in South Carolina, you've been providing care to your patients who are stuck in New York or stuck in Chicago, you have to make sure you understand what your state's rules are today and what Illinois or New York state's rules are, because they're coming off pandemic emergencies. And so those governor or federal emergencies change. And so therefore some things may not be covered any longer. So you really have to pay attention. So I want to turn to South Carolina for a minute and commend the South Carolina Medical Association. Here is some information on what happened in South Carolina. And I have to say, and I've been giving presentations across the country and I've looked at all the state sites, your state has probably the most comprehensive information on what each health insurer is doing and what the state is doing. And that's to the credit of the South Carolina Medical Association and its aggressive advocacy and communication, not only with the governor, but with the governor's staff. And so the governor helped out in this case, which I really haven't seen in other states, and pushed the health insurers gently, or not too gently, to immediately make changes. So South Carolina, despite not having a large number of COVID cases, at least initially, had some of the most flexibility and transparency of your insurers. So in many states, you can't figure out what the insurers are doing. You go to their site, you can't find information, you call them, you're online forever, they don't give you the right answer. But in South Carolina, we'll show you they've done a lot. So here's some state resources. So you can see the state resources and where they are. And now we're going to talk a little bit about provider impact and what you need to do. And then we're going to turn back to some of those insurer examples. So I tell everyone for best practices for telehealth that you really have to start with the fact that, do you have a compliance plan? Think of it like any other service you're going to provide or start to provide. Do you have a process? Have you identified how you're going to bill for it and who's going to do it in your practice? Don't just turn on a switch and start doing it. Make sure you know and have a plan in place. It's going to help you from a liability perspective. It's going to help you from a reimbursement perspective, and it's going to help you from a care provision perspective. So have a plan in place and know how you're going to bill. Step one, also in this plan, have leadership in the practice that is going to be the individuals who are leading the telemedicine, telehealth process. Consult with an attorney, whether it's your own personal attorney or the medical society's attorney. Consult with attorney to understand what some of the regulatory and legal requirements are. Consider a platform that is compatible with your existing infrastructure. If your telehealth product can't communicate with your EMR or your billing system, that may not be the right one for you. Develop clear policies. You need to have policies in place. Again, this is to protect you. This is in case anyone comes back for an audit. You need to have policies in place. Who's doing it, when they're doing it, how you're documenting, how you're billing, and where that information goes. Does it go into the telehealth system? Does it go into your EMR system? Does it go into your billing system? Where does it go? You need to also have a compliance plan. If someone violates that process, how do you rectify it? And you need to provide training to not only the clinical staff, but the administrative staff, not just how the telehealth system works, but on the entire process from setting up a patient encounter until billing the patient. Everyone in the practice, just like they do now, needs to understand how you're billing and how you're seeing that patient. Think of the telehealth environment as a new office, as a new practice site, and what you would do with a new practice site and how you would train your staff clinically as well as administratively. Also, you need to define some elements of that plan. Documentation, 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 patient privacy, confidentiality, and security. Now remember, I said a lot of these things are waived by the federal government, the HIPAA requirements, but they're only waived during the pandemic, and the pandemic is coming in some respects to a close, at least when it comes to the federal orders. So pretty soon, some of those HIPAA requirements, unless extended or waiver extension, are going to come into play again. So make sure you understand what those are. And God forbid you had a breach, you need to know how to communicate with the patient or patients for which there's been a breach and how to handle that. And this is an important one, the last one on this slide. Confirm medical liability coverage. You will not believe how many physicians have coverage that is evergreen, and there's no language about coverage for telehealth or telemedicine. It's silent. You don't want it to be silent. You want it to be covered. Some insurers have riders. Some insurers have separate actual coverage. They call it cyber coverage. Some are part of the coverage. It depends upon your insurer and how old your coverage is, because some of those evergreen are silent. So you'd want to get that taken care of and get something in writing in confirmation that you have coverage. Step 3, this is just common sense. No bad faith conduct. Do not violate state or federal laws. Don't do anything that's public facing. Don't do anything that's inappropriate. You still have to protect patient PHI, that's patient health information, personal health information. To recognize it's an emergency, things are going to change. You need to stay on top of it. South Carolina Medical Association is a great place to go for that information. PAI, CMS sites, your state, again, DOI is a wonderful site to go to. It's the most easy site I've seen from a state perspective to visit and understand. Go to those sites. They're updated and they're helpful. Step 4, you've got to know what the billing requirements are, the changes to the modifiers. And you're going to need to know what documentation you need to put in your medical record, paper or electronic, so that when someone comes back in a year or two, you've got something there, because they're not going to audit now, but they have not said they're not going to audit in the future. In fact, CMS just came out and said they're auditing the money they gave, the $50 billion. They're going to be doing some audits, the OIG already, on the money they gave out not the telehealth portion, but the dollars. So I bet you donuts to dollars, they will come back at some point and start evaluating this. So have documentation. CPT codes have remained unchanged for many of the visits. In other words, it's the same CPT codes, but CMS is requiring for place of service, again, 11 or O2. Generally, they've shifted from O2, which the place of service was your home, to 11, which is your office, because more physicians are now in their office doing it, and using either the GT or 95 modifier, depending upon the circumstance. And the CPT code book explains that. I believe all in South Carolina insurers explain that, again, through the DOI, and your state Medicaid also identifies which modifiers they want you to use. On step 4, examine those codes that are changing every day, and consult with the AMA again on some coding tips because they have some good information. Use a HIPAA compliant video solution. Make sure that if you're using something that's a little more flexible now, that you can transition. You can transition to something that will protect you and cover you after this emergency. And as I mentioned, review the coverage, make sure you know what's in it, talk to legal counsel. Here are some questions. I'm not going to go over all of them, but some questions you need to ask a vendor if you do not have a telehealth or telemedicine system in place. What are the terms? How long will they last? Is there any cost for you per use? Is there any cost for the platform for the consumer? Is there any additional charges? Is there an out-of-office messaging feature? Remember, real-time digital, what happens when someone clicks and doesn't get you? Is there a message? People forget, that they're clicking, they're thinking you're home, you're there because it's online. Is there a direct message capability? Can you communicate in an electronic digital fashion that's not an email to share patient health information with the patient after the call, after the digital interaction? And how is the patient's medical history recorded or captured, if at all, in the system? Those are the basic questions you'll need to ask. I'm not going to go through this in detail, but these are some things you can look at after that. The AMA explains how to do a telehealth visit, a visual check-in, and a remote visit, and what that means. Let's talk about kind of the nuts and bolts of how you get paid. So Blue Cross and Blue Shield came out nationally and said that all of their plans are going to allow telehealth and waiving co-payments and co-insurance. But it wasn't that simple because every plan is different and independently owned. United said no cost sharing, but they only said through March 18th. They've since, it's effective March 18th, for 90 days. They've since said that they're going to expand it. Aetna said it's only valid until June 4th, which is right around the corner. Humana said it was effective March 24th, and they had no end date. Just to give you an example of 3 insurers. United presently covers 46 different services, but they only cover them through June 18th. Aetna covers 27. Humana covers 150. So you see the variability among health insurers is significant. Going back to Blue Cross of Tennessee just recently was the first insurer in the country that says we're going to keep this virtual visit in network immediately, not out of network. So not someone in Florida or South Carolina that isn't in network, but any in-network provider that's providing telehealth, we're going to let them continue as an in-network provider providing these services and pay at the same rate. First insurer in the country to do that. Premier Blue Cross launched some virtual things that are unique and different through an app that they said they're continuing. So again, other insurers may follow Blue Cross and Blue Shield of Tennessee, but it's the first one to say, pandemic or not, we're continuing this. So let's talk a little bit about the South Carolina DOI website. Again, I've mentioned multiple times how easy it is to navigate. This is thanks to the South Carolina Medical Association, the governor, and the DOI. This is the actual site. I just cut and pasted, so we're going to go through it. And it shows you each insurer, what they've waived, and when you click where to get more information. There's no other government site in any state like this that has all of this through a simple click. And again, I'm showing you on 3 slides because I didn't want it to be so small, but each plan that's active in the state of South Carolina has all this information up and is updating it on the DOI site. So you see right now Absolute, Aetna, and Blue Choice. Then you've got Blue Cross Blue Shield, the South Carolina is listed separately, Bright Health, Cigna. Again, Some quick snapshots. This is all from the DOI, from the insurers and what they're saying, but then also ways to access additional information. Clover, Humana, Molina, and Select have additional information. It tells you what it applies to. Again, this is great because it's a one-stop shop, and if you need more information, you simply click on the insurer and it jumps right to their site where it has it. And United Healthcare, this is their information. So it's actually 3 pages and a little bit of one. But again, you can get to this through the DOI website in South Carolina and then get to each insurer and directly where that information is. So you don't have to fumble through their main website or contact a network contact to get anything. Go to the site. If you then have questions, go to one of their network specialists. Some health insurers are making it difficult. In Connecticut, Anthem said, oops, we're sorry, we changed the policy, but we forgot to change our billing system and reimbursement system, so we haven't paid you for them. We ask for your patience. It's been 3 months, we haven't paid you, but, be patient, we'll eventually get to you. Some insurers are better than others on paying. Some insurers, day one, when they turned it on, they started paying. Others, there's been a delay. I encourage all of you to look at your claims as they come in, your EOBs, your RAs, see what hasn't been paid. Don't simply think that because they said they're reimbursing you that those claims are getting reimbursed. Make sure that they are. What are the barriers to this technology? Just to close up before we have some Q&A. Some technology isn't available in every location. You've got a cost. Most of these are purchased by the provider, not by the patient, and there's a cost. You have to have consent. You have to have consent of your staff, your physicians, and the patient in every case. The coverage for some of these services may be lower, where for others it may be the same. So you have to make an informed decision whether you want to get half as much to do a telehealth visit or if you want that patient to come in. Credentialing privileges and network issues before COVID were a problem tied to telehealth. I think it's going to be one after the fact. Medical liability, some carriers, again, do not cover. Licensure was variable along with prescribing before. It's been suspended, but I'm sure it's going to change again. And of course, be cognizant of HIPAA, privacy, security, and confidentiality, because God forbid you want to violate that and have the Office of Civil Rights coming in to look at something. You don't want that to happen. So here are some provider resources. Again, I did not list, I should have the North Carolina site because South Carolina, because I listed it separately. But these are some national sites to get some additional information on what payers are doing. So let's talk a little bit before I close on really what's changed. So this was a recent poll actually done yesterday. It came out. Everyone thought seniors, Medicare patients weren't going to do telehealth. No way, they don't understand it. But this poll showed of 1,000 seniors, 52% are actually comfortable using telehealth. That's a bigger percentage than I thought, with only 30% uncomfortable and 18% unsure. And of those surveys who are using it, 91 said they had a favorable opinion of it. So of that 52%, 91% actually seem to like it. And 78% said they'll use it again. Now, what's also interesting is that 73% of seniors on Medicare Advantage plans said that they had their needs addressed through telehealth services or in person. So they see it as not just a supplement, but potentially right now as a replacement. So that's the senior population, and they seem to be turning towards it. Here's some other things about the outlook. One health system in New York tried to turn on in 1 month 1,300 physicians into telehealth services. I don't need to tell you what a mess that was to turn that many in. My suggestion for practices that are even as small as 3 or 4 physicians is stage your physicians and other providers on the telehealth. Don't put everyone up at once, stage it. So if there's any problems, you find out immediately. It's not 4 people seeing patients for a day that you have, it's 1 person. So stage it. Also, a recent study showed that 48% of physicians are now using telehealth services. I think it's even higher than that. That's up from 18% just 2 years ago. Blue Cross of Western New York said that last year they paid for 135 telehealth visits in March. Remember, it was very limited, restricted to certain services and to certain people, and you had to have certain requirements. This March, it was 20,000 telehealth visits. Blue Cross in Massachusetts said that they've seen a spike in claims because of COVID to 1 million telehealth claims. That's 38,000 telehealth claims per day that they're seeing. There's a transition overnight where many of these things that was going to take 5 or 10 years before we saw some of this technology really connect happened overnight, and in some cases has happened so quickly that people haven't been able to keep up. Half of the visits in Massachusetts were behavioral health visits, telehealth visits. Again, one of the last things we thought would happen, we being the medical community, was that the behavioral health was going to jump online and do telehealth services. But nearly half of those, especially because of what's happening with COVID-19, have been mental and behavioral health. And Blue Cross said it added 400 providers to help with these services. What is a barrier? And a barrier I know in South Carolina, in some places, having spent almost 20 years of my life spending summers in South Carolina, there's a significant lack of internet access in parts of not only South Carolina but other states. 35 million Americans, or about 10% of Americans, don't have access to internet at all, and about another 30 million lack decent access to internet that would allow them to engage in telehealth services. That's not just patients, but that's physicians as well. There are physicians in South Carolina and other states that simply can't do these services in their offices or at home because they don't have the internet services available. So it is rapidly changing. So with that, I know I've spoken for about 40 minutes. I'm opening it up for questions and happy to answer any question there is. I will tell you if I don't know the answer as well.
And I'll just jump. Matt, thank you so much. I want to unmute your line or chat. Either one is fine. I think I'm echoing off your other screen, Matt.
I'm sorry?
I think I'm echoing off your other screen.
Okay, well, let me see if I can change that.
It's okay. I think they can hear me, but we can see your chat, or y'all are welcome to take off mute if somebody wants to ask a question. We appreciate Matt coming, and just so y'all know, we got him through, he mentioned PAI, and we use PAI a lot as the SCMA. That's an organization that has several state chapters associated with it, and it works on billing issues. And that's why Matt is part of that. He consults on these type things, and they provide us federal help with billing, like surprise billing or any of those issues. They help the SCMA get a hold of it, and we are part of that organization on the board. So we're very grateful for that. And with that, if there's somebody that wants to ask a question, feel free to at this time. And if y'all want to chat with any, and while he does that, I'll just talk about Blue Cross Blue Shield a little bit. Matt has been checking here. He mentioned that in Tennessee, they're the first group to say that they're going to continue to cover everything. And our Blue Cross Blue Shield in South Carolina hasn't made a permanent decision. Right now, they're continuing telehealth, and they're sort of watching what's going on across the country, how long it's needed. But they're also checking in with physicians and seeing who's going to continue the services. I think some physicians have said that when the pandemic is over, they're not planning to continue telehealth. And some have said, no, this is great. My patients like it, and I do want to continue it. And I think that shapes each of our states. So one thing we're looking at is what doctors' opinions are on telehealth, those that are using it. I've heard several doctors say that it's quite difficult because of all the coding and the different restrictions on insurance. I mean, it's just like your regular visits, except it's a whole new layer again. But one thing I think Blue Cross is looking at is if they continue it, will physicians use it once the HIPAA restrictions are back and you have to use a specific platform? So I think that's part of this puzzle. And if you don't have a question, but you're interested in sharing your thoughts of that, we would love to also hear that. As I think that's part of seeing where our state will go and if telehealth will continue to be a big influence. Matt, while we're waiting for somebody to jump in, can you tell us if there's a state that you think telehealth is going the best in? I'm curious if you've seen that.
I'm not so sure I would say the best, but I do think that they've adapted the quickest, both from a physician and health insurer perspective, as Massachusetts. And I don't know if it's because there's bigger systems there. Did you lose my picture, or am I still there?
You're still there.
Okay.
Right.
Or not, but the transition to use not just for medical but behavioral and mental health has been quite substantial, and patients haven't complained and doctors haven't complained. But that's in part because the Blue Cross plan made some early decisions to pay what they were paying at the office level and to encourage the physicians to use whatever technology they could in order to connect and not restrict them. Many of you may be aware that some of the insurers used to require, before the pandemic, and some still do, you use their technology, which is even more complicated and in some cases convoluted, and they may even charge you for it. So in Massachusetts, the insurer made a, I think, smart decision. The physicians readily jumped to it. There's a lot of big systems, so systems jumped to it, and the patients adopted and adapted to it. I think that they're doing a good job. I think that in some other states, it's much slower to move. New York, not just in the Manhattan, lower Manhattan area, but in the upstate area, and I gave that example in that those rural areas, because that big state, because New York is geographically big, was under a lockdown, quarantine, stay-at-home order. Even though most of the pandemic was in the 5 boroughs and the lower part of New York, those rural areas had no way to access physicians. So it seemed that because of that, and it happened so early, that by March, they were using it effectively. So some of this has been driven by the pandemic, and not in a way that because of the need. So here in Connecticut, we had some very early problems with the pandemic and physicians and nurses being impacted at our hospitals. So it took them out of the game into quarantine. But we were short physicians. So what do you do if you're quarantined? If you can't see your patients, you can use telemedicine to see your patients. So many of those doctors, hundreds, didn't get COVID, but they were limited in seeing patients face to face. So they transitioned to telehealth very quickly so that they were able to see their patients. And because many of these doctors weren't hospital employees, but they were on-call physicians from the community, they were able to continue with their practices and didn't see a full stoppage of care at their practice level, which helped them financially. So I think COVID has driven a lot of this, and where there's hot spots, you've seen a lot of transition to it. But I see it personally. My belief is it is a supplement and a temporary replacement for some services, not a permanent replacement. It should be a permanent supplement to that face-to-face direct encounter and engagement. And even some of these other apps and technologies are great. They are wonderful and they're helpful, but you need to see your doctor face-to-face, real time, in person. But in some of those rural areas, if there's transportation issues, if the doctor isn't feeling well, this may be a way of supplementing moving forward. But right now, for many locations that are hotbeds, it's a replacement.
That's great. And we are going to send out the presentation that was asked. Nicole's just answering it to everyone. It has the links embedded in it. And I've got a question for you. Someone has asked if you could go over again the section on federal funds and grants. And you mentioned that it's not really going to independent practices to help with telehealth. If you want to cover that again, and then I can fill in on the South Carolina side and where we see some grant money coming.
Sure. So there are 2 main ways to get telehealth, telemedicine funding tied to the federal government in South Carolina. They would be through HRSA, which is part of CMS, which is the health resource area. They're giving out grants based upon specific populations that you are caring for and specific locations. So rural care, Indian Health Service care, senior care, those with chronic conditions. But they're not giving it to individual physician or physician practices. They're giving it generally to systems, community care centers, teams of practices teaming up. For example, there was a hospital with a community medical group that got one of these grants. There was a 4 different practice group that got it. They're not giving it to one entity there unless it's a hospital or FQHC. They tend to be giving it to groups of physicians coming together because they want to cover a broader area. And they know a 3-person practice isn't going to be able to impact the area quite the way that 5 3-people practices can. So that's through HRSA. FCC is giving their grants more for telehealth, telemedicine infrastructure. They're giving it to hospitals and clinics and big systems. It sounds funny, but they gave, and just because you wouldn't think of this, they gave over $1 million to the Yale New Haven Health System here in Connecticut for carts to put the telemedicine equipment on in physician offices and in the hospital, because again, they weren't using it before, so there was no way to go from room to room or to take it with them through, if they needed to, different locations. So they are paying, the federal government, FCC gave $1 million to the hospital system for the technical carts that connect to the iPad or the computer, so they were more mobile, and they could go in between different locations, to their clinics, outside of their hospital, to the community, using those services. So they're making it even more remote than before. But you wouldn't think that the federal government would be paying for carts for computers, but that's what they did. That's what they paid for. There are grants available. If you go to the HRSA website, I had the links in there, or the FCC website, the links were there. It lists grants. They're on a rolling basis. So every few weeks they list new grants. There's a 2 or 3 week window to submit. Then they make the announcement and more grants go up. And they're going to do it until they give out for the $200 million under the FCC and the $180 million under HRSA. So the money's there until they use it, and the grants keep popping up. It wasn't a one and done. So go there to look, and there may be a grant that fits you, especially if you're in a rural community or very urban. You're serving a population that is disadvantaged when it comes to access to care. Many of these grants are available to you if you're teaming up with other entities.
That's great. Well, and I'll just add, in South Carolina, there's sort of 3 avenues right now in telehealth, but only one of those is specific to telehealth. We actually have the South Carolina Telehealth Alliance, and many people may not be aware of that because telehealth wasn't a big thing in South Carolina. But if you actually Google South Carolina Telehealth Alliance, you'll come up to their website, and they have resources, and they give out funds for pilot projects of up to about $25,000 every year. I'm not sure if the window is closed right now for 2020. I know I've seen the 2019 awards on there, but they give out several every year to help grow telehealth in South Carolina. And so there is a local resource that provides that, and they do different projects. It just depends every year on working through that. And I know MUSC actually works with them and some other groups. And then as far as expanding it further, it's really going to be broadband grants. The state put together a package through the Accelerate SC, and the report came out yesterday advocating for a lot of the money to go towards expanding broadband. And all of the General Assembly hasn't accepted that. I expect that will happen. And we've seen a lot of utility companies suddenly pop up to help on that as well. So that's going to really be in rural areas. But we do have a mechanism in our state statutes to allow for broadband access in rural areas through our utility companies. And so these smaller co-ops are now working on it. Again, it's one of those chapters that had been ignored, but there's a process for trying to fund that, where the utility can put in part of the money, and the state puts in part of the money, and the feds put in part of the money. So that's being used to expand internet broadband to areas where telehealth and also the schools can access better broadband to make this happen. So that's going to be 3 pots, but one is specific for doctors, and that is if you go to the South Carolina Telehealth Alliance, they do different awards every year to help expand telehealth. And I'm not familiar with this year's, but I do know they've been doing them since 2015, and they do a pretty good job of granting those every year.
And I want to say 2 other things tied to the money issue with telehealth. South Carolina Medical Association does have a relationship with an HIE that does do some funding, I believe, as well, tied to EMR and telehealth services. I don't know how that works effectively, and how it works specifically in South Carolina, but I know that there's a process through the HIE for some funding as well. And then finally, as you all look at your practice to see what your losses were tied to COVID-19, don't forget to include the expenses, the training, the evaluation, and everything you did to get your telehealth and telemedicine services up and running. People often forget you're buying new technology, you're training staff, you're changing your processes, you're buying additional computers or additional equipment. Don't forget, when you look back at what happened during this period and if you had a loss, to not only look at lost revenue, but look at expenses that you've incurred tied to the transition, at least in the short period, to telehealth services. If you continue those services, the ongoing expense that you may not have had or probably wouldn't have had if it wasn't for the pandemic. But those are the kind of things you're going to want to keep track of to understand how much you're spending or how much you lost tied to the transition to telehealth during this difficult time. And if you keep on using it, that's great. If you stop using it, that's great, but still know how much it cost you and how much you lost as a result of the during this period for pandemic. It will help you as you look at things such as your budgets, such as your insurance, and the like. So make sure you understand better how that works.
And there are some consultants that can come in that help you with telehealth and how to use it and make money off of it in your practice. There's different things. And I think some of the telehealth software companies probably at some point, I don't want to recommend groups and things like that, but they're definitely coming out with grants and different things to make it more popular. And I think as COVID ramps down, now that they have a lot of people on their platforms, you're going to see them offering some free training and different things to keep you engaged and to help with those costs, because this is a big boon for them as well, to get people using the services that had never tried it before. So I think we'll see some more dollars coming out from those sides. And we certainly have seen a lot of companies. I know we've sent out in Med News companies that have provided free telehealth services for 6 months and software. We've been sending those out for people that want to try it. And there are some free ones that already exist for basic services, but a lot of companies are trying to help physicians give it a whirl for free.
And just be careful of some of those free items and their contracts that say they're free for 30 days or 90. And if you don't terminate in 30 or 60 days, you're stuck with that annual subscription rate that's quite high. So make sure, in looking at the contract, that free is free, that you understand when, if there is a termination, what it is, when you have to give notice, what kind of a notice. It's almost always a written mailed notice and not an email or call. And because you don't want to end up spending that $399 for a free system that you used for 1 month. So it makes sure you're aware of that. The health insurance systems that they offer or that they own, just be cognizant of where the data goes and who controls that session, whether it's you or the insurer, who's shutting it off, who's dealing with the determination of what to bill, and who owns the data. And again, some of them are quite good, some of them aren't so good, but asking those questions are important.
It's a great reminder. Do we have any other questions on telehealth or Matt's presentation on these different issues?
So I answered everyone's question, and you're all going to go out and do telehealth tomorrow, right? You're going to go jump in, and you're going to do it stepwise. You're going to have a plan, a compliance plan. You're going to not have all providers switch over on the same day along with the physicians. You're going to do it stepwise. You're going to try it. And I would suggest having a champion in each practice that's that first person to do it. There's going to be issues. There's going to be technology issues. There's going to be practice workflow issues. There's going to be scheduling issues. Just bear in mind that you're doing this to help ensure access to your care for your patients. And for most of these insurers, they're paying you the face-to-face rate right now. So you're not losing anything other than the cost of the technology to just try it. The question becomes later on, what do you do and whether you continue it? And that's got to be a business decision based upon your practice environment and what you feel comfortable with and what your patients feel comfortable with. And make sure you get consent before you start doing this with each patient, and that you have an understanding of their consent. And you don't want to have one of your partners say, well, I didn't really want to do this. So yes, I had an appointment with them, but I didn't really turn on the computer. So make sure that everyone in the practice is willing to do it. If they're not, then make sure that your staff knows that, so that they're not being signed up for a time slot where that system's going to go completely unanswered, because you'll lose patients that way.
Well, that's great. Nicole, do you have anything you need to provide at the closeout? Oh, you're on mute.
I apologize. I do not. I would like to thank you very much for taking out the time to join us today. There will be an email coming out to you sharing with you how you can claim your CME credit for today. I'm always available at South Carolina Medical Association, where you can reach out to me with any questions or concerns. Please stay tuned because we will be having further webinars coming up each month. I thank you again for your support.
Thank you, guys.
Thank you. Thank you for allowing me to do this with you today. Take care, everyone.
Yeah. Matt, thank you for this.